I'm just going to take a second and talk. I know not everyone who's going to join us is here, but just to kind of pick it up, I'm Michelle Barnes. I'm the Director of Human Services for Colorado, and I'm also the chair of the Behavioral Health Task Force that Governor Miller's put together. There's a couple other task force members also here. So would you introduce yourself? Sure.
I know about the business facility, and the Southwest. I'm also the CEO there, and I'm on the subcommittee of the pediatrics and children's task force.
Which I understand we're defining children as possibly up to 26.
Lots of discussion about that. I think it's the same answer.
Hi, I'm Laura Warner. I'm the Director of Operations at Public Health, and I am a part of the long-term competency subcommittee. Working on folks who are that are helping folks who are involved in both the behavioral health system and the non-justice system.
And so we have one other subcommittee, which is on safety net, to make sure people are following through the plans. And it's also a really important subcommittee, and then we have maybe task force. And just for context, this came about after some discussions with Governor Miller's when we started, that it became clear that mental health and substance abuse and just the larger definition of mental health is impacting millions of Coloradans, whether directly or through someone you love. And so he suggested that we really be bold and put together a task force that's looking outside of just, okay, what's one change we can do, what's one goal we can run, but looking more integrated and say, let's work with providers, let's think in a big picture of what we can do to really change things for the better for Coloradans. So this is all about the patient-centered system. And so we have about 100 Coloradans like this who have volunteered to spend a lot of time over the next year helping put this together. And one important component of it is hearing stories of people that have interacted with the behavioral health system, either personally or through a family member, and making sure that that they feel heard, that we're witness to their stories, and that also we use it to inform decision making. And so we've had providers speak, we've had parents speak, we've had family members speak. We've had a whole variety. This is our fourth session, and they are wildly important. There's probably some other committee members on the phone that will come and go, but if you give us permission, we're recording it and we will share. If that's not okay with you, no worries. That's absolutely fine. We still want you to share your story with the people in the room, and that's really helpful. So today isn't to solve the problem for the people that want to share their story. It's to understand the system and what's not working for all Coloradans. So I can tell you for me, having heard this is my birthday testimony, and I'm just looking at Doyle because you were at the one on Friday that you did as well. Once you hear your stories, they're in our soul. And so I can tell you that we may not remember the details of it, but you'll remember your stories, your challenges, and your successes with the system. And you really feel sacred to make sure to make it better for you. We're really excited to be able to do this in Durango. And we have some people calling in, so I don't know if they're from this area or if they're from another area, but we just want to hear from you, and we don't want to intimidate you. That's not bad. And so we'll just let you come up. You take about 5 minutes. Tell us what you want to tell us. We're not going to do a Q&A because we can ask for your permission to go into the hood and what you want to share with us, but we're here to listen and support you. So you can see that people can access. I appreciate that. I'm going to hand it over to Summer Betterpool, who's on the phone, who's the head of the Behavioral Health Task Force. This is a big project, isn't it? So Summer's full-time project manager, and she's in Denver today. So she's going to kick this off. Can you hear us, Summer?
Hey everyone, this is Summer. Yes, I can hear you. It sounds a little bit muffled in the room. So when we have speakers in the room there in Durango, if you wouldn't mind pulling the phone a little bit closer to the speaker so we can hear clearly on the phone, that would be fantastic.
Thank you, because I'm on the phone and I haven't heard anything that anybody's saying. Thank you.
Thank you.
great. We'll try to speak a little bit more clearly. And really just appreciate everyone taking the time to share their stories and recommendations with us at the task force today. As Michelle shared, these testimonies are being recorded unless you ask for them not to be recorded, which is totally fine. We can pause the recording during your testimony if you would not like to be recorded. Also, as Michelle said, we are looking to keep the testimonies to about 5 minutes each. Once we start going over that time, I will try to gently jump in and just give you a warning that we're over time. For those of you who are on the phone, if you can hit *6 to mute yourselves, that's great. If you are participating on the phone and planning to testify, you can unmute yourself by *6. So just use *6 to mute and unmute yourselves. We really want to try to minimize the amount of background noise. And we do have about a dozen people today. It sounds like maybe there's a couple people that walked in that hadn't signed up for testimony. So we're excited that you were able to join us as well. And we'll definitely fit you in. We'll do our best to stay on schedule and just appreciate everyone's flexibility as we go through this. So I want to jump right in, and our first person today is Jane, is it Macubri? Jane, are you with us?
I am here, and it is Macubri, although I never expect anyone to get that.
Well, thank you for your patience.
No problem. Okay,
Go ahead and take it away.
All right.
And while you can't hear us that well on the phone, can everyone hear? This is great. We can hear you very well.
Oh, extremely good. That is lovely. That's always the first
And
question.
Jane, there's about 15, 20 people in the room.
Okay, good. Thank you. Thank you. Okay, so first of all, this is Dr. Jane Macubri. I teach remotely for University of Southern California from, I like to call my corner office here in Denver. I am here today to talk about something that's very important to me, which is the effect of benzodiazepines on public health, health in general, and the effects of health changes on people's life. And so I agree completely that this is being recorded, and if my cell phone image would cooperate, I would be able to read the legalese. But yes, I know it's being recorded. I'm fine with that. And this is my electronic signature. Okay, so let me start with some background facts. Benzodiazepines were first marketed in the US in probably the early mid-60s. They were to be originally, and they are still, according to the physician's desk reference, to be used explicitly for short-term use, less than 2 weeks, and for major psychiatric disorders and epilepsy. In spite of that fact, they have come to be the #1, #2, #4, and #7 most prescribed medications in the US. There's a river of medical studies from the 1960s forward showing us that BZDs, benzodiazepines, are linked to everything from falls and fractures to auto accidents to Alzheimer's and dementia. And there's no question about that because there are tons of medical studies, and if anyone wants me to forward them, I have some significant ones in electronic form, and I can easily send them to you so you can see that for yourself. So there's a convergence of a lot of evidence that benzodiazepines are an issue. But when I had my own personal brush with a benzo, which I won't trouble you with, I realized, because the first thing I do as a social scientist is go do my homework. So I went into the National Institutes of Health website and fairly shortly discovered there had been no large-scale study of the symptoms that benzodiazepine patients suffer when they're on the drug, when they're trying to withdraw, when they are finally withdrawn. And I thought, well, damn, I can do that. I mean, that's in my wheelhouse. So I teamed up with the Benzodiazepine Information Coalition. Chrissy Huff is in Fort Worth. And we had final results from about 1,200 people in the early part of 2019 and have been in the process of analyzing that. So what I want to talk about today, and I'm going to exit full screen here so I can go to my own desktop and talk about this. And if I was lucky, I was able to get a physical copy of the 3-page handout that I created for this testimony to back it up, to show you the actual data. And of course, I'm willing to provide that to anyone else who wants it as well. What we did most recently, well, first of all, of course, we did an analysis of statistics across this database of 1,200 people. And then recently, we split it down into 3 groups. Those people still on a full dose of benzos, those people tapering, trying to get off, those people fully off. And these results were kind of astonishing to me personally, because I had no idea until we split it this way that people on a full dose of benzos have almost 70% have sleep disturbances. Almost 70% have difficulty focusing. Almost 70% have memory loss. Almost 50% have trembling and tingling in their body. Almost 55% have nervousness, anxiety, and fear. Almost 50% are sensitive to light, talk, sound, and smell, which means basically your everyday environment. Almost 60% have balance problems. Almost 50% have difficulty walking or driving. Almost 50% have stomach and gut issues. Almost 40% are weak. Now, the interesting thing about splitting this into 3 groups from my personal social scientific perspective is that we're able to see that there's a huge number of people on a full dose, as I just reviewed for you, who have these issues. And an even bigger number of people who are tapering who have these issues. 92% have low energy. 94% have sleep disturbances. 91% have difficulty focusing. And in the off benzos, I don't want to read you this whole table. I'm willing to send this little handout to anybody who wants to see it, but the group off benzo is almost as bad. 97% have low energy. 90% have sleep disturbances. 87% have trouble focusing. 78% have memory loss. When I read you these, it should not surprise you that a lot of people off of benzo say that they lost their job, or that the effect on their work life was an enormous problem. 76% lost a job, 33% lost wages, 41% faced increased medical costs. So what I'm trying to say here is this has been a problem that's under the radar because the studies on this have been published in such a myriad of fields and journals that probably no one in the medical field really understands that these symptoms, which are sometimes diagnosed as psychiatric disturbances, sometimes diagnosed as fibromyalgia, the medical field doesn't know what they're doing, I'm convinced. I have solid faith that all of the doctors in 4 different states that prescribed these things to me did not know, because they all told me there are no side effects and it's non-addictive and you can stop whenever you want. And that, of course, is BS. So my concern here is to bring this to your attention because we normally think of behavioral health as something individuals are doing to themselves, like getting involved with addictive drugs. In this case, the behavior is taking a prescription that your doctor has recommended and that you were not told was dangerous. You were not told that you might have these symptoms. There may be, I hope there will be, I pray there will be a bill in the Colorado legislature soon asking Colorado to be the first state in the nation to ask for informed consent. And this is frankly for two reasons. It's the fastest way to get doctors to understand what may happen and what they may have to deal with if they have a patient who decides to take them. Now, there's also, of course, no question that for some people with major psychiatric problems and panic disorders and GAD and that sort of thing, there's no question that it helps them, right? And there's no other solution that anybody knows of. So there's no question that they help some people. But the fact that they are prescribed, as they were to me, for insomnia, for situation anxiety related to a horrible work situation in my case, I should have been told that if I took more than a few days or weeks of these, that I would have years in which I would have to deal with the physical consequences. So,
Hey, Jane, you have about 30 seconds left. I just wanted to give you a warning.
yeah, that's fine. And that's my message, essentially. I'm happy, you know, this is, in fact, in the United States, the very first ever large-scale study of these symptoms. It is. And so we're going to try to publish it to the medical community. But, oh, I forgot to say, oh, yes, there's a very high incidence of suicidal thoughts. And there's maybe about a quarter of our participants reported violent thoughts, doing damage to other people. We also know that the Los Angeles shooter and the Parkland shooter both had been on these drugs. So this is just something I'm trying to bring to the attention of the mental health and the public health communities. And I appreciate very much you allowing me a few minutes to talk about this.
Thanks, Jane. That's really helpful. And we did get your handout, and we'll make sure to disseminate it to the members of those on the task force who are participating today, and then we'll share it on our Google Drive as well for the rest of the task force members.
Super.
And we did circulate it in the room here, so.
Oh, that's awesome. I know we just completed this additional analysis just 48 hours ago. So I got it to you as fast as I could.
Well, it worked. I love it when it all works out. Thank you so much for sharing that. That's really great and helpful data to have.
You are welcome.
All right, I think with that, we're going to move to our next person who's going to testify. I believe she's in the room, Katie Drobny.
Should I say yes? I am in the room.
Yeah.
And again, I just want to remind you guys to move the phone as close to Katie as possible.
How's this sound? Just talk this
Oh,
way.
that sounds great. Thank you.
All right. Excellent. Excellent. Hi, everyone. So I'm Katie Drobny. I'm over at Pediatric Partners. I'm one of the behavioral health counselors over there. And my job right now, it's great. There's 3 different locations that we are at, our main campus over at Durango High School and over in Bayfield as well. And one of my team members is here and she's gonna talk later too. So I've been at Pediatric Partners about 2 years now, and involved with integrated behavioral health probably since about 2010 or so, starting over in Washington State. And so that's kind of what I'm here to talk about today, is my experience with an integrated health model, specifically around one family who, gosh, I think I've been working with pretty much the whole time I've been at Pediatric Partners, highlighting some of the challenges that came up, and then also talking about how collaborating with a lot of the agencies that are actually in the room today here really felt very successful, and it felt like we were able to hold the family. And I don't have any statistics that sound very smart at all compared to our last presentation. However, so the family that we were working with, the way we were introduced to this family was actually with a mom who came in for a pre-visit, just kind of wanted to check out what was going on and talk to us about her pregnancy experience, and then her other children at home just kind of came up in the process of that. So Hispanic family, both parents were living here, 5 kids total once she had her 5th one. And what we started finding out right in the beginning when mom was pregnant, one of her main, or 2 things that were going on with her that were really adding a lot of stress to her pregnancy was that, one, her husband was working nights, and so she was in charge of all of her kids at night and pregnant at the same time. And as we started talking about and meeting her kids, started realizing, gosh, there's a lot of social determinant needs here. There's a lot of mental health diagnoses with almost all of the children. And there were a lot of safety concerns at home, particularly one kiddo who would get pretty violent at night, and mom was feeling threatened several times while she was pregnant and really couldn't defend herself towards the end there. So this was a family that was already pretty wrapped in our community, you know, accessing services with Access Health, San Juan Basin Health, the school district, the kiddos, most of them were on IEPs at school as well, so had good school support, good counseling supports. And then crisis happens in the family. The oldest kiddo had to go into inpatient treatment. While he was there, it was deemed that he needed a longer stay. He was transferred to another facility, and in that process was exposed to and contracted tuberculosis. And so layers on layers start happening. A few other things that I put in the social determinant category at this time were that mom at that time, I think, had just given birth. Dad was also afraid that he was going to get deported, so he was actually in Denver at the time, just kind of laying low. So we start having meetings with Department of Human Services, who at this point is now involved as well, talking about what's it going to look like when this kid comes home, and what does this family need, and how are we going to support them. So we started talking about what services were already in place. ABA, the Applied Behavior Analysis services at home were in place. However, because English was the second language for both parents and they didn't have an interpreter at the time, they weren't really able to utilize those services the way they really wanted to. So I think at that time is when the in-home services from Access Health were involved, and they had a series of unfortunate events. This family, all of a sudden, that therapist isn't working there anymore, so the in-home supports are gone. Human Services is kind of coming and starting to work with some family therapy, but soon realizing that there is a lot more need than just family therapy. And then that's when these meetings started happening, where we all came to the table and we just said, hey, what's going on and what can we do to help? As the older son is transitioning home, other siblings are starting to have a lot of stress-related behaviors, and it resulted in multiple ER visits, especially for one sibling in particular who her head banging got so bad at school that teachers couldn't help and control her. She didn't have a one-on-one aide. They weren't trained in how to restrain or help her, so she ended up in the ER quite a bit. Once the older sibling who was in the inpatient treatment facility came back, supports were in place as much as I think they probably could have been. However, you know, glitch number 2 pops up. All of a sudden, you see them on our schedule as, oh gosh, mom didn't end up getting enough tuberculosis meds to finish the course of treatment, so she was hoping we could refill that for her, which we couldn't because we actually didn't hear from any facility that this kiddo was diagnosed with it or it was given this prescription. So it was probably 5 phone calls from one of our providers until we finally figured out who had diagnosed him and if he was in fact positive or not and what the course of treatment was supposed to be. And then at this point, a lot of agencies were going, gosh, should we maybe not have these kids come in for their appointments for a little bit until we know if they're you know, positive and if we're having like an actual public health risk here. So brakes kind of were put on a lot of things, which was really hard for the family because they really felt like the ball was starting to roll and services were in place and case management was happening. And I think what was helpful in the beginning for us is we have a model over at Pediatric Partners where we risk stratify our patients. And so this family, when we started meeting them, were all of a sudden put in our, okay, in crisis or on the verge of crisis list of kiddos. So we were able to meet with them more frequently. We got to utilize our Medicaid six session option for a little bit of counseling and case management and care coordination, mostly with the Department of Human Services at that time.
Hey, Katie, you have about 30 seconds. I just wanted to give you a warning.
No problem. So what really worked, I thought, was being able to risk stratify, which is a very common practice. You know, I think it's like 90% of our kiddos now are risk stratified in our practice there. So knowing who have bigger needs as far as social determinants and mental health, being able to offer them behavioral health visits in the moment when things were not going well for those kiddos at our office. Being able to have monthly staffings with Access Health and Human Services where we can bring up this registry of kids and say, hey, where are you guys at with them? Here's where we're at, and do we need to coordinate services any further? And being able to invite the school district to come to some of our meetings as well to talk about how to wrap these kids over at the schools that they were at too. So a lot of successes and a lot of barriers to overcome and a lot of really great coordination and collaboration agencies here. We could definitely use more supports in this area.
Thank you.
You're welcome. You're welcome. Thank you guys.
Thanks, Katie. I think next we've got Leanne Shaw, who's going to be joining via Zoom.
No, I'm here.
Oh, you're here. Great.
Hi. Good afternoon.
Good afternoon.
Hard to follow these people.
You're good.
So my name is Leanne Shaw, and I work as a behavioral health consultant at Pediatric Partners of the Southwest. I've worked for them part-time for the last 4 years, and the last year full-time. We're close to it. I've had some medical challenges. But today I was going to bring one patient example just because I think it elaborates several systems pieces that we're having challenges with. So my goal of coming today is to use a case example of the challenges working with the adolescent population when services are not available in this area and the frustration to access higher levels of care for adolescents in need. The patient in question that we're talking about today is a 14-year-old Hispanic female who was adopted from the foster care system. She has struggled to engage in previous years due to high turnover of providers with Access Health System. The patient would have really benefited from the RYFS program, but keeping that position staffed has been challenging. That's a position between the Department of Human Services and the Community Mental Health Center, but they do home-based work. The patient finally engaged when we opened up a Bayfield clinic and has attended multiple individual sessions and numerous co-visits with her primary care provider. I believe this engagement occurred for 2 reasons. 1, the location was convenient to her home, and 2, the patient felt connected with the integrated care model, seeing the doctor and the behavioral health at the same time was very effective for the parent and the child. The patient has attempted suicide twice in the past 9 months. Both times she was taken to the ER and evaluated by Access Health System crisis team. Both evaluations resulted in a safety plan with the mom of client who had allowed the patient to access her medications that she was using to overdose on. When reviewing the crisis assessment, the risk factors did not reflect the severity of the situation, and the recommendations that were put in there are not accessible in our rural health system, such as intensive outpatient therapy. Despite stating that the family needed therapy, Access did not schedule an intake for the family or make any further recommendations. The crisis worker both times did not consult the primary care provider or the therapist who works with the family. If the crisis worker had reached out to our offices, then we could have shared our concern for this patient's high risk and the need for additional supports. The patient is on medication and is working with Children's Hospital of Colorado Psychiatry through our telemedic clinic to manage her meds. She has been referred to Radical Possibilities through Lopata Youth Services, but has not yet had an intake due to coordination with her mom, and has asked for equine therapy, thinking it's been very beneficial in the past, but the cost is $75 an hour and they don't accept insurance. In the spirit of doing the brief therapy model, which we are asked to do in the integrated health setting, I've been working to refer her to an outpatient therapist who can do regular, ongoing, intense weekly therapy, but she's been in crisis and transitioning many times, and it's not the best practice to push her out the door when she's falling apart. The patient also has a brother who has severe mental health and physical health challenges along with substance use. He is in his 30s and on probation and living in the home. He has a history of being physically and verbally aggressive towards the mom and the patient. Access has been trying to get him into a co-occurring program such as the Circle program, but he's been on the wait list for over 6 months without success. During that time, he has assaulted the patient, yelled and threatened the patient, and the police have responded to their home numerous times. The police now refuse to take him into custody unless a major offense has been cited, because he cannot get the medications he needs in jail and his health is too fragile. And it's not because they don't do meds, they do, but they have certain restrictions on the meds they do. He is also an Access patient. Access has failed to find housing or inpatient treatment for this patient in the past year, and his behaviors are negatively impacting the patient that I see. Mom has now lost her job and is struggling to find work. They are in financial crisis, and this is escalating the patient's issues as well. A successful plan would be to have a community case manager that can work with the family to obtain resources such as including food, financial, work support. A therapist and a case manager should be working with the adult sibling to help him find housing and treatment for his complex issues. The patient needs to have individual and family therapy weekly to improve her dynamics and reduce suicidal ideations. In order to improve the quality of care for this family and others like her, we need to improve communication between agencies, along with making plans of care that are accessible and feasible that are effective. I feel that collaboration, communication, and other levels of care in our community, such as in-home or community-based case management, safe respite, and a higher level of care for adolescents being more accessible to our area.
Wow. That's a lot of story in about 3 minutes.
I tried really hard, and she's like, get it down to 4 minutes. So
That was great. Thank you for advocating for your client. Appreciate it.
Is Douglas McCarthy in the room with you all there in Durango?
I'm here. Hello, everyone. I'm Doug McCarthy. And my wife Susan and I are both local residents of Lopata County. We have a 12-year-old son who has diagnosed behavioral and emotional needs. We fostered him from birth, and we were thrilled to adopt him a year later into our family. Our journey in seeking services for his needs has been a difficult one. And I'm sharing that with you today and really appreciate the opportunity that the task force is affording people like us to do that so that we can improve the experiences for other families that might come after us. My wish for the behavioral health system is that it would become more proactive and coordinated. Currently, from my perspective as a parent in a family, it appears that the system tries to triage the use of expensive services by waiting until there's a crisis. And I think everyone would agree that's counterproductive. It would be so much more effective if there were resources for the system to be preventive and to catch those problems, what they say, upstream before they manifest in a crisis. Our son's a perfect example of a child who really would have benefited from that kind of an approach. He was known to the system since birth as having neurodevelopmental trauma in utero, and yet there was no plan, no coordinated effort to connect him with services, to create a care plan, and to provide guidance to us on a trajectory and a path. And by saying this, I'm not suggesting anyone failed in their job. Throughout our experience, we have been served by people of good faith who really wished for the best for our son and for us, but yet that sincerity doesn't result in a system of care that serves us well. I'm just going to use an analogy since this is Durango. We have a lot of river rafting companies here. And when you book a rafting trip, you get a helmet, a life preserver, a paddle, and you're told how to work with that river guide to navigate the rapids and to get downstream successfully. Well, in that analogy, I would say we were given none of those things. We were kind of just shown to the river, given a hope and a prayer, and cast upon our wits and our ability to yell for help to anyone on the shore, to to see our need. As our son began experiencing behavioral challenges in elementary school, we sought out experts and they tried to be helpful. But in hindsight, we see that they were hampered because they didn't have a big picture of what was going on with our family. Some providers to whom we were referred would have been wonderful. We could have accessed them, but they weren't available. They were busy. And others were very focused on, let's say, medication management. And there was no holistic approach to helping us or my son. I don't think we rose up to the level of a crisis in the system and the risk assessment. And so we just kind of floated along. But through my wife's persistence, we were fortunate to see Dr. Heidi McMillan at Pediatric Partners here in Durango. And she was able to understand our situation, make a referral to a private practice psychiatrist who diagnosed our son, prescribed a whole suite of treatment, and connected us with the school district to establish an individualized education plan, or IEP. And with the support of caring teachers, he successfully completed elementary school. So we thought, wow, we're on an upward trajectory. But then we hit middle school. Unfortunately, that's really a difficult environment for someone with behavioral challenges. His applied behavioral analysis therapist abruptly moved, and that sent my son into a tailspin. He refused to go to school. He became increasingly violent in tone and engaged in life-threatening behaviors. When we called the local crisis intervention line, we were told they did not have any help for children. So we were directed instead to call 911, bring the sheriff to our home and transport him to the hospital, and that happened 2 times, which is very distressing. We realized that this trajectory was trying to prove need, and that we were kind of being coached to prove that need through these visits, and that was traumatizing in and of itself. So I'm going to make kind of a distasteful analogy, but we felt like laboratory rats wandering through a maze, enduring electric shocks to get to that food pallet that might help us. We were being conditioned to conform to a broken system that offered us uncertain help and benefit. By chance, I learned about the new collaborative management program, and I met with the local individual services and support team, or ISST. And I really appreciated that, but it really was too little too late. I would have loved to have met with them years before if that program had existed. What really disturbed us is that we learned that in order to really get the residential help that we thought our son needed and we needed, we might have to surrender our parental rights to do so. We decided to break this cycle. We didn't want any further trauma for our son or ourselves. We decided to invest in an outdoor therapy program recommended by experts to stabilize his functioning, and he's currently in a therapeutic boarding school where he's been making steady progress academically and behaviorally. We're excited about that, but in order to do that, we're spending down our retirement savings, and that will eventually be exhausted. Once those funds are gone, we will have no further resources to rely on should he require longer-term intensive services. So in summary, I would just ask the task force to consider families like ours, and I would urge you to create a more responsive system that will harness the goodwill of professionals, the cooperation of schools, and the lived experiences of families like ours, so that there is a more proactive assessment, care planning, and coordinated services and supports that will promote better outcomes for families like ours. That's going to require 4 things, in my opinion: a convincing vision, committed resources, sustained effort, and authentic collaboration among stakeholders. I really feel that the well-being of children like ours and our society depend on that. Thank you.
Can I just ask, you said it was going to require 4 things? You went really fast.
Yes, I have a copy.
Oh, that'd be great. Just for the benefit of people in the room, do you want to reiterate what your 4 things were?
I think a convincing vision, committed resources, sustained effort, and authentic collaboration among stakeholders.
Thank you.
Thank you, Douglas. I want to check in. Is Donna Middleton in the room?
Good afternoon, everyone. My name is Donna Middleton, and this is Phil Middleton. It is an honor to be sitting here, sharing my story with all of you today. I am a proud mother to my 21-year-old son, Andrew, a young man living and learning every day from his recent dual diagnosis of schizoaffective disorder. 4 years ago, our lives as a family changed forever. We were at a family work event, and with what should have been a beautiful evening together, left us with feelings of hopelessness, confusion, and anxiety. At the time, Andrew was only 16. We had noticed substance abuse, risk-taking behaviors, and volatile, brash, and negative attention-seeking behaviors. They were shocking. Things escalated quickly, and at that moment, I knew. I will never forget when I looked to my husband and muttered, "I think our son has a mental illness." Those words have been the scariest and most devastating words I have ever spoken to this day. We were desperate to find Andrew help immediately. As we blindly navigated our way through our local and regional options, we realized this is going to be an out-of-pocket experience, as many mental health providers in our area do not work with private insurance. After many sleepless, tearful nights, it was confirmed. In June of 2016, Andrew was diagnosed with bipolar disorder. After a road of failed outpatient treatment options and tens of thousands of dollars out of pocket later, Andrew landed in a pediatric psychiatric hospital for a month. We found that at this point we were able to start getting help and support for ourselves as caregivers to this new chapter of our lives. We were able to enroll in a 12-week family-to-family course that was being offered in our community through the National Alliance of Mental Illness, also known as NAMI. This was a very textbook and clinical approach to mental illness, and we wanted to immerse ourselves as much as we could before his return home. It was an incredible relief and really left us feeling comforted, supported, and more equipped to help our son. However, we couldn't help but notice, where was everyone? There were only 3 or 4 other parents enrolled with us. We found ourselves wondering how many people were out there who felt like we did, simply just uncertain with what the next step should look like. Once the classes ended, we were left with wonderful knowledge, but we struggled to find any sharing groups for caregivers, families, and friends. Hope was the furthest from our minds. After months of living with the ups and downs of managing this new life, Andrew had become a senior in high school, and he was angry. He wasn't playing football, mountain biking, and kayaking, all the things he was passionate about. He was having to learn an entirely new way of life that involved taking medicine daily, that left him feeling horrible, and he began to live in a constant state of paranoia and fear. We later found out that he was experiencing delusions and hallucinations, and he was scared to even leave his bedroom. We found ourselves in Colorado Springs, another stay in another psychiatric hospital. Our sweet boy was now diagnosed with schizoaffective disorder, a short year after his initial diagnosis of bipolar disorder. The hospital was able to stabilize Andrew with his new dual diagnosis, and we found ourselves experiencing hope for the first time in years. As Andrew became more stable, we were able to regroup and really focus on what we needed most as his caregivers: support. Not only for ourselves, but for our community that seemed to be quietly struggling as well. All the emotions and stress that had come with this nightmare and the feelings of isolation and sadness were incredibly overwhelming for us as parents. Andrew will always need his family to support him, love him, and be there for him to fall back on when he experiences challenging moments in his illness. We know our path as a family and as his parents has changed, and we are okay with that. We will always do what we can to support both of our sons, even if that looks a little different for both of them. In 2019, Beacon of Hope Durango was founded by me and my husband, Phil. Our heartfelt mission is to provide a safe place for caregivers, families, and friends to support each other and share in their experience with mental illness. My husband and I craved more than sharing challenges and successes as a parent, and we felt confident enough with our journey that we may be able to share and provide solace for even just one other parent experiencing this. This is just what Beacon of Hope does for our members. We believe there is hope for all of us as caregivers. Our longstanding dream for our group is to get the word out that we are here for whoever needs support, encouragement, and a safe place to share their challenges and successes with their own journey as a caretaker. We are here, and we want you to be here too. We want to share with you, and we want to learn from each other. But most importantly, we want to spread hope that you are not alone. We hope to one day become a nonprofit that collaborates with local providers and offers our sharing group to anyone who may need us. Thank you for having me here today, and I leave you with a quote from actress Glenn Close. What mental health needs is more sunshine, more candor, and more unashamed conversation. Thank you.
Oh, thank you. That was great. Thank you. This is Stacy Albert.
Stacey Russell.
Russell, yes, me again.
Hi. My name is Stacey Russell. I work for Access Health System here in Durango, and I am a native Coloradoan, which I'm very proud of. I grew up in a rural area in Colorado, and I developed a passion for nonprofit work early on in my career. So it's exciting to be here today. And one of the reasons that I love Colorado is because I know that there are many people here that care about each other, they care about their neighbors, and they care about their community. And that keeps me grounded to Colorado. Today I want to talk about some of my priorities as a mental health professional. And some of the things that I think about is engagement of our patients. That's been a really big push from a state perspective. And in preparation for today, one of the things that I did is I went through and looked at engagement from our first appointment from a patient perspective. So I actually did all the paperwork and sat down and went through that process, looked at our population screen, and then kind of did a mock session related to what our state requirements are for each of those sessions. For our, it's the Colorado Client Assessment Record, there are 63 data points that we're required to gather as an initial uptake for our patients alone. I am a nerd, a self-proclaimed nerd. I do love data, and I will confess, I'm the first one to say that I like my spreadsheets. I have 3 screens on my desk, and I'm okay with that. And so I have a high value for data. And I do think that Colorado has a great opportunity right in this moment to really look at what data we're gathering and what are we doing with the data that we're gathering? How is that providing value to our patients related to their outcomes? Right now, we have a system that we're data rich. We have lots of data. What we don't have is I feel like we're outcome poor. So I think this is a great opportunity for Colorado to look at how much money are we spending collecting our data, and are we truly prioritizing around that data to ensure that the data we're gathering isn't just interesting, that we're driving outcomes with that data. Because that's one of the big challenges for a community mental health center is we do have a lot of different programs and a lot of different mechanisms. Which goes back to something that someone said earlier when they were talking about their loved one. Their loved one is a whole person. So for us in a community mental health center to try to fragment someone out related to their substance use, maybe challenges, their mental health issues, if they've had a crisis call, if they've been to jail, if they've been to the emergency department. I think that the collaboration is really important, And what we have to do is put our patients at the top and be able to treat effectively and allow people to come to recovery by focusing on outcomes.
Thank you very much. I like the data rich but outcome poor. I don't like it, but I like how you phrase it.
Thank you, Stacy.
Are you sure?
I don't, okay, so we've got Carrie Francis Countley. Perfect. Great, thank you for joining us.
Thank you, and I'm very nervous, so I apologize.
Just take a deep breath.
So I originally came here to speak more about my mom, but I just kind of found out about the task force yesterday. And so kind of a little unprepared a little bit, but I do want to share two stories. First, my son. When something that I keep hearing that's reiterated throughout this conversation is a lack of support. So I went through a horrendous high conflict divorce, and I knew there was something wrong with my son. And people kept looking at me like, it's your fault, it's your this. And I kept reaching out for help, and I would get like 2 minutes with a behavioral health with integrated, and they're like, oh, well, here, go over this place. And we put him in counseling. And 6 months later, that counselor would quit or they would change. So it's right when they were starting to get attached, right, starting to have a bonding, we would do this. And we would keep doing this for a couple of years. And my son developed increases. And he is now almost 11. And
can I ask, just in case anyone in the room doesn't know what that is? Like me, what that is?
So encopresis is actually when you develop defecated stool in your bowels, and then you end up having explosive diarrhea because there's so much defecation, it squeezes around there. It can be caused, and the number one cause is psychological. And so we went through special GI specialists, and we got a lot of great help getting a person to come down from Children's Hospital, and we got to see them here. And they'll always said to us, it's all psychological. And there's no reason why your son should be doing this. And then we would try to get psychological help, and every 6 months, we would be trying to reestablish, get back in. And then when the problems I have, and it goes back to this data collection, maybe 2 out of the 8 meetings, we literally spent the entire hour collecting data versus therapeutic care for my son. So he didn't get any bit. And I sat there in that room, and all the conversation was directed towards me and nothing towards me. And during this time too, I didn't know what I was doing, but I felt like it was all my fault. And I couldn't live in the situation I was in, and yet my child now has an adverse experience. And finally, and he still has increases to this day. And we finally found someone who started working with him more holistically, naturopathically. And for the last 6 months, he's not had one accident. And he's at the age that this is truly embarrassing. It's caused him to have major social issues in school. He doesn't even have a good friend. And I live in a great community, but I didn't know how to circumvent that or where that early intervention needed to happen. So sorry, I'm a little careful. But mainly I came here to show you a story of my mother. So mental health is not abnormal in my family, and I've got to deal with this most of my life. My mother is a wonderful woman. She's now over the age of 65 with multiple chronic conditions. Recently, she faced severe depression. And because of the way Medicare B is set up, Medicare in general, we couldn't get her help. She couldn't get in to see anybody, and she was told she had to wait 6 weeks, basically, as the waiting list because of her health insurance. And so she spiraled down and down and down, and I didn't know what to do for her. And then finally, she came to the point where she almost tried to commit suicide, and we ended up in inpatient. So we were able to get her help through that facility. But my question is, why did we have to wait to that point when someone has to take their life? Why do we have to wait till crisis? Why can't we intervene early? If the one thing that we looked at through all of our help through the years is preventative care works. Preventative care is cheaper than waiting. I mean, it is. I mean, we have all the data and all the information, but it's more profitable to wait until it's too late. It's more profitable for a lot of people, and patients more costly, you know? But is it more profitable to our souls, to our community, to the productivity of our society? And I don't really think it is. But one of the reasons why I bring this up is our biggest provider for Medicare in this area is Access Healthcare, and they serve Archuleta, Montezuma, and La Plata counties. There are a few other providers. So I just kind of did a few calculations because I am also a data-rich person and I do like my numbers. Just to kind of get you, that's 96,233 rural populace that it lives in this area currently, according to the U.S. Census in 2018. And looking just roughly at those who are over 65 and those who are disabled, that's 26,836 individuals that qualify for Medicare. But however, Access Health only serves 2,000 of those individuals. Only 2,000 of those individuals, and they're full. They cannot take on anybody due to the lack of providers. So that's a lack of access to healthcare. So that's roughly 90% of our population in these 3 counties and about 24,000 individuals that don't have access to mental health care. And on the other part of that, the reason it's an issue is that only 5 out of 50 providers can actually provide that mental health care due to the way Medicare and Medicaid is doing that. I look for solutions, I look for hope versus dwelling on the problem. So when I looked at this and I was like, why cannot my mom get help? Why am I going through all this rigmarole? And it's just, we have 2 major blocks. And so I challenged this task force to look at the legislation, to look at the rules that our providers have to follow. And are these good rules? Is this a good thing? And should we be, you know, taking it to a federal level? And that's kind of what I want to say is that we need to do that. The CMS doesn't break down visits per county. They only break it down per state. So only 0.4% of Medicare coverage went to psychiatric costs. That's very little. And we are a whole being. The mental health is only part of our medical. So we spend so much more money on these medical issues. We don't even see how a person is emotionally or is handling the world, or even how to do something is part of that mental health. We ignore that factor. We don't spend our money and effort on it. So there are 2 growing problems I keep seeing in this and that I've been looking at is the Social Security Act of Section 1833C. Actually says limits payments for incurred expenses in connection with treatment of mental, psychoneurotic, and personality disorders. The law goes on for payment purposes to limit 62.5% Medicare approved amount called the outpatient health treatment limitation. However, there's no limitations for diagnostic service, just therapeutic and mental health diagnosis and tests. So I'm going to say this, if I was in surgery and guys operating, oh, reach my 62.5%, what are you going to do? That's not going to happen. But we're more than willing to risk that with our heads, with what controls the rest of our body, what affects the rest of our body. Nobody really looks at how much mental health really affects diabetes. How much does it really affect our cardiac conditions? When you feel like crap and you feel like that, are you going to get out and walk for 30 minutes 3 times a day? Are you going to choose to like cook or go to these different like healthier foods? It's not going to happen. But yet we're only willing as a society to pay for 62.5%. So then another solution I was thinking that needs to be considered is the qualification requirements for mental health providers. Currently, from what I can see, only licensed clinical social workers and clinical psychologists can may see this vulnerable population. So that's only 2 types of individuals. Medical health has actually expanded its doors, especially with the Affordable Care Act, to help grant more people with access to health care. And why they did that, they allowed PAs, allowed NPs, they allowed all these other parts, but mental health still got punished. And yet it's a huge component of our health system. So just to give you an idea, we're these through rural counties that we live in, we only have 7 licensed clinical social workers in the area seeing patients in this insurance bracket. 5 of them are at Access Healthcare. So that leaves out your licensed professional counselors, your licensed mental health counselors, and your licensed family. All 3 of those require master levels. They also require extensive hours of postgraduate experience. And I understand like some of the issues that we're going between federal and state. The problem is that we need a task force, we need our government to take it to the federal level. This can't just be solved statewide. This has got to be solved on a federal payment as well. If these people cannot treat our population, I don't know what to do, you know? So the current system, I feel, is biased. It's not, we're allowing for worsening health conditions for vulnerable populations. And unfortunately, it's just going to grow in the coming years. We are at the edge where the baby boomers are going to just bloom in the next 5 to 10 years. And currently, right now, 45 million individuals above the age of 65 has 3 or more chronic conditions. And that's huge. How do you think someone mentally copes with being that disabled? And if we cannot help them get through that, if we cannot provide them with groups or provide them with a way to meet people to help them cope with their condition, then what are we doing as a society to help them? So that's one of the things, like, you know, through my mother's mental illnesses and even my son's, like, difficult struggles that I never had that support. And that is not one single time was I ever asked, what support systems do you have in place? And that's something I think, like, we talk about a data checklist, but what supports that person that's getting help? Do they have the support that they need? And what type of groups can they do be provided? Because I would just like, I mean, I'm just the person who digs for information. I dig to find out a better solution, and I keep going until something works. And that's kind of what I hope happens. But these are some things that we can look at as a group to figure that out. So, kind of in a nutshell. Oh, and then actually, I recently interviewed one of our doctors in psychology here, and one of the most striking things she said to me in the interview was, we would like to say we match you with the best persons for your needs. But in reality, we look at your insurance first. And that is really sad. We are no longer people. We are who you are insured by. And it's frustrating. I mean, we're supposed to be individuals, not just a number.
Beautifully stated, thank you. Your mom is very lucky to have you.
Okay.
You know, I think a lot of times.
Okay, so I'm pretty nervous, so I'm probably just gonna read right off this and not look at you guys a whole lot, so don't take it personally. Hello, I am Emma Ann Harmon. I'm a suicide attempt survivor, a community member, and a Durango native. I am one of the lucky ones. I could not be here today. I'm alive and stable, and that is no small feat in the face of my mental illnesses, trauma, and chronic suicidal ideation. However, I cannot give the current behavioral health system any credit for my stability and improved behavioral health. A year ago, I walked into the main behavioral health system here, Access Health Systems, and told them I needed an appointment very soon because I was struggling with depression and chronic and severe suicidal ideation. I was told I would be seen in 6 weeks. To some, that might not seem like a long time to wait, but to someone struggling with active suicidal thoughts, a day can feel like a year. So imagine how I felt waiting 6 weeks to receive help when I was struggling to get through each day. After barely making it through the 6-week waiting period, I walked into Access hopeful that I'd be receiving help and treatment from a therapist. Instead, I spent over an hour relaying my personal history to some stranger that then told me I would need to make an additional appointment to create a treatment service plan before I could see a therapist. I would need to wait 3 weeks for that appointment. I couldn't believe what I was being told. I had to wait even longer, and I would not even be able to speak to a therapist at the treatment service plan appointment. I asked to see a psychiatrist as well, and they said he was booked out quite a ways and that we would talk about that at my treatment service plan appointment. I walked into that visit heavily hoping and desperately needing to see someone for therapy and treatment, and walked away empty-handed, defeated, and hopeless. I was running out of time, strength, and stamina quickly. I couldn't fathom having to wait longer when I was already barely making it through each day alive. A week later, I almost attempted suicide, but I knew I had a family to take care of, and I knew to seek immediate help, especially after my failed suicide attempt in 2014. I knew I needed to get help right away. So I walked into Access Crossroads Crisis Center at 5:15 p.m. with severe and intense and active suicidal thoughts, and was released within 45 minutes because the crisis therapist did not believe I would harm myself. Or maybe he just wanted to be done with his shift so he could leave at 6. Regardless, I was released and unstable and not okay. Thankfully, I have a wonderful support system in place, and I had the strength and knowledge to reach out for help again later that evening. 3 of my friends stood up at my doorstep within 30 minutes and sat with me to make sure I was safe and created a safety plan with me moving forward. A dear friend of mine paid out of pocket for me to see a private therapist the very next day, and for however long I would need until my work insurance kicked in, which would allow me to seek treatment there instead of with Access, since I only had Medicaid coverage at the time. However, I still wanted and needed to see a psychiatrist. Access would not allow me to see their psychiatrist without having a service plan with them that included 2 weekly group therapies on top of a weekly therapy session. I had a good and strong relationship with the private practice therapist I was already seeing, and I asked if my therapist could send a letter or call them to let them know I was receiving ongoing treatment so I could receive some psychiatric care from Access. Access was adamant that I had to receive all services within their system. Plus, I'm a single, full-time working mother. I couldn't commit to that plan even if I wanted to, because I simply do not have the time or the care for my child. So I decided to seek treatment through a private psychiatrist for when my work insurance would kick in. The soonest available appointment was 8 months out. I booked it and hoped I could make it until then. During the 8 months I waited to see the private psychiatrist, my primary care provider subscribed me over 12 different medications targeting my depression, suicidal ideation, and anxiety. Nothing helped, and I eventually gave up trying, and no one followed up with me anyways. I've had 2 visits with a private psychiatrist within the last 2 months, and he has prescribed me 2 medications that have tremendously helped. While I am incredibly happy that the medications are helping me, it is disappointing and frustrating that I could have had relief and treatment for my mental illnesses over a year ago if I would have had timely and efficient access to a psychiatrist. I will tell you what has helped and why I am stable today. I have had a wonderful foundation and privilege for working on my mental health over the last year. I have had consistent and weekly access to an amazing private therapist and EMDR therapy, access to behavioral health providers, specifically private psychiatrists, access to behavioral health medication, superb health insurance coverage, the most amazing, strong, and understanding crisis team and support system that allows me to call or text at absolutely any time, as well as self-care and coping skills that my therapist has worked with me on. Because I have the privilege and access to a full-time job that offers incredible health insurance along with a flexible schedule that allows me to receive treatment along with a strong support system, I am thriving. However, that has not always been the case for me or the case for many other individuals. There are so many other individuals that do not have the foundation, access, privilege, and support system that I'm allowed to have. I stand here today disappointed, appalled, and disgusted with the current behavioral health system. It is allowing so many people to fall in between the cracks. If I did not hold the privilege I do hold, and I had to solely rely on the current behavioral system, I would not be alive today. But like I said, I'm one of the lucky ones.
Wow. Emma, you're the exact reason why we have a behavioral task force. So we will keep the story in mind.
Yeah, thank you.
Right.
Yeah, thank you.
Hi, I want to thank you, Emma, for your story. That was really helpful. All right. I'm not really big on speaking to adults either. I feel more comfortable in a playroom with kids. My name is Annie Diaz. I'm a licensed professional counselor, and I'm the mental health therapist with Montezuma County Department of Social Services. In deciding whether or not to come here today, I thought about Dr. Seuss. Unless someone like you cares a whole awful lot, nothing's going to get better. It's not. Despite a fear of public speaking, I am here today to give testimony about our needs in Montezuma County.
As I mentioned, I'm a licensed professional counselor and I specialize in trauma, attachment, and play therapy. I've lived in Montezuma County since 2015. I worked first at Access Health System in Cortez for 2 years and was able to obtain my license. I left Access in 2017 and accepted a position with the county which had a dual role, implementing a mental health program for child welfare and working as the primary therapist for the New Wings Day Treatment Program, a collaborative effort to help children who behaviorally cannot function in traditional academic environments. Fortunately, this summer, they hired a full-time therapist for the New Wings program, so I've been able to dedicate my time to child welfare. In preparing for this testimony, I felt the weight of all the challenges faced by our community on a daily basis. In Montezuma County, we are severely lacking in providers and programs to serve our increasingly high-need area. I spoke with clients, their family members, other therapists, and administrators in order to accurately present to you our needs. According to the U.S. Census Bureau, Montezuma County is continuing to diversify. We currently have people from white, Native American, Black, Hispanic, Latino, Asian backgrounds, and individuals of mixed race or heritage. We currently have a poverty rate of 15.2%, which ranks 14th out of 76 in our state. In addition to high levels of poverty, statistics from 2017 show that we have the 4th highest suicide rate, more than double the statewide average. In our community, we have the following resources to address these significant challenges. As I mentioned before, Access Health System in Cortez, it's our only community mental health center. It serves the entire county. It currently has openings for 2 full-time child and adolescent providers and 4 adult providers. Currently, they're relying on providers traveling to Montezuma County from other areas to help serve our population. Access has high turnover rates, in part because individuals either relocate to Durango or are living in Durango, and the commute is too much. When I worked there, I frequently felt overwhelmed with an extremely high caseload and an inability to see people with enough regularity to make a significant difference. Furthermore, I was the only bilingual Spanish provider and tried to help anyone I could with not only their mental health needs, but also case management and medical translation. I often saw Native American clients rely on family members to translate during moments of family crisis. Four Corners Youth Clinics is a school-based health center located at Southwest Open School campus and the Dolores School campus. They have had a part-time position listed since June and have received no licensed applicants. Mugan Behavioral Health Center is a new organization located at the Ute Mountain Ute Reservation. It was created to address the high needs of our Native American community in culturally sensitive ways. They have 2 openings for therapists. They report the challenge of obtaining licensed behavioral health professionals and inadequate salaries for individuals who are providing these services. The Dolores School District currently has an open elementary school counselor position as well as secondary school social worker position that are not filled. They report many struggles, including finding qualified staff and locating resources for families who do not have or do not qualify for Medicaid, leaving schools with extra pressure to provide a wide array of services. Other schools in Montezuma County are reportedly fully staffed. Smaller schools often do not have a school counselor to provide supportive services. These schools rely heavily on licensed clinical social workers and psychologists from the San Juan Board of Cooperative Education Services, BOCES. These individuals travel throughout the county and have various schools on their caseloads. Schools who are fortunate enough to have a school counselor or social worker in addition to BOCES rely on that individual for academic recommendations, crisis interventions, counseling, family outreach, social emotional curriculum, and connecting families to community resources. I am the only therapist with Montezuma County Social Services. I provide child protection therapy to parents, interactive therapy to parents and children, and trauma-focused play therapy to children involved in the child welfare system. The Child Advocacy Center, which is our community's resource for children during the investigation and prosecution of child abuse cases, only has 1 therapist as well. She is a licensed counselor who provides trauma-focused cognitive behavioral therapy and other therapeutic interventions to children impacted by trauma and abuse. She actually lives here in Durango and has been commuting to Cortez for the last 5 years. I want to thank her for that. She has been asked to provide mental health services at the middle school because although they received a grant for a full-time therapist, they were unable to secure a qualified provider for this school year. I know 5 private practice counselors in our area, and only 2 other than myself who provide services to children and families. A couple of us often rely on sliding scales or providing services pro bono to meet the needs of our community. I also spoke with several foster adoptive parents, caregivers, and kin. They report there truly is a frightening shortage of qualified mental health professionals for this area, especially for low-income families. You can't be seen right away unless you're in crisis, and you can't get appointments reliably afterwards. For kids in the community, unless they're already in the system or have experienced such significant trauma it can't be ignored, there is practically nothing. Another individual said, this community is lacking compassionate people who genuinely care. When those individuals do show up, they quickly get burned out from all the physical and emotional exhaustion. I do see sources of support. I would say that those individuals who have chosen to reside and or work in Montezuma County are some of the most dedicated and passionate people I have ever met. We are spread very thin, often wearing multiple hats and trying our best to help everyone we can. After speaking with others, the following seem to be areas we can improve mental health resources in Montezuma County. Incentives to live and work in Montezuma County, such as salary increases and student loan forgiveness for teachers, school support staff, and mental health professionals. More local training opportunities and incentives for local providers to get more culturally relevant education so we can meet the diverse needs of our community in sensitive and accurate ways. More education on behavioral versus psychiatric diagnoses for community members so the high volume of clients and limited psychiatric services can be prioritized. More psychiatric services. Thoughtful, collaborative, and organized distribution of resources such as time-limited grants to make sure we're providing the most services we can instead of doubling up where other organizations are meeting the need. More opportunities for behavioral health collaboration with streamlined releases of information so agencies can work together more effectively. More opportunities like this to collaborate on a larger level to develop the support for smaller rural communities. I want to close by being very clear. The work that I do inspires me every day. I feel truly honored to work with amazing and resilient children and their families who are trying against all odds to recover from oftentimes generations of poverty, substance abuse, and trauma. Providing adequate and culturally sensitive services to these individuals and their families will contribute to the stability, health, and progress of our community. I hope that in this time, I have represented some of the unique challenges faced by the people in Montezuma County and our critical need for more support. To remind everyone in this room, unless someone like you cares a whole awful lot, nothing's going to get better.
Thank you for putting that perspective on.
Okay, so we're going to go ahead and start with our final speaker.
So welcome. If you wouldn't mind introducing yourself, jump right in. We're a friendly crowd.
My name is Stephanie Allred. I'm a psychologist, and I am the Senior Clinical Director at Access Health System. And I would like to talk a little bit about parity regarding behavioral health. So 2008, the Mental Health Parity Act law went into effect. 11 years later, we still have significant gaps in true parity for both mental health and especially for substance use treatment. We have still a lot of discrepancies, which really impacts behavioral health access for our Colorado population. So there's differences in providers and what insurance companies accept in terms of reimbursement for providers. There's differences in pre-authorization requirements. And we are seeing the demand requirement for insurance companies requiring pre-authorizations for outpatient treatment. So pre-authorizations, it's an understandable kind of control mechanism for high-cost care. I get that for inpatient care, whether that's medical, whether that's behavioral health, but to require pre-authorization for outpatient care is, I think, overkill. The cost it takes for a clinical staff to get through a pre-authorization process and the demand on patients as well. I mean, that would cover the cost of a therapy session right there. So it's really putting resources in the wrong direction. Again, huge discrepancies in substance use treatment coverage. In Colorado, as a mental health center, we are regulated by the Office of Behavioral Health. We are required to have certified addictions counselors on staff. They have very solid training specifically to treat substance use disorders, but private insurance companies do not reimburse for CAC level providers unless they also have a mental health license. So this is a discrepancy in terms of what providers patients have access to, and of course, as a provider, getting reimbursement for those services. There's also discrepancies in network adequacy. Again, as you know, accountability for insurance companies to have adequate network for behavioral health. Behavioral health, people seeking behavioral health are 4 times more likely to have to go to an out-of-network provider for behavioral health compared to medical. So that's a huge cost to patients. And again, another barrier for individuals to actually seek out care, which is already hard to seek out and have the courage to ask for that assistance. So those are some significant barriers that I feel like we have a responsibility to try to address. So the mental health parity law is a federal law, but states have a responsibility for enforcing that law. And so there's a Mental Health Parity Compliance Act that is being discussed. And if that's something that's going to help, again, have increased accountability for a range of insurance companies to be in compliance with the law that was passed, again, 11 years ago. I think that would be a huge shift for us. So I think mental health has gained traction and gaining better coverage, but again, there's still gaps in substance use treatment coverage. I think it's a huge step for the state to have Medicaid potentially cover residential treatment for substance use disorders. But again, there just needs to be better consistency with all plans, not just Medicaid, to make sure that people have access to care that is effective for them.
Thank you. That was really helpful. And I will make sure our Commissioner of Insurance for Colorado hears your testimony. That was excellent.
Thank you.
Well, yes, I want to thank everyone again for taking the time to share their testimony with us today. And then for anyone who is listening or watching, just want to encourage people to participate in one of the upcoming testimonies. If you have not already signed up, there is a list available on our website. We've got one scheduled each month through January, most of which are in the Denver metro area. We did just schedule one for Grand Junction on October 22nd. So for those folks that are on the Western Slope, really want to encourage them to participate as well.
And Summer, you may not know, I just heard that the Lieutenant Governor is scheduling one at the Ute Tribe in November as well.
Oh, good. I had not heard that yet, so I'm glad it was confirmed.
Thank you, everyone, for coming. I really appreciate it. And I appreciate the bravery of so many of you sharing really personal stories. I just know that we heard them in the manner we meant them to be heard. So I appreciate everybody for speaking up and helping us do a better job. I think the task force members here, we're having lunch together tomorrow, where you're like, okay, we got stuff to do. So thank you for informing.